This presentation is going to cover the introduction of the SBAR communication tool in a rural acute care hospital in Western New York. This tool was introduced in January 2010 for a trial period that ended June 2010. Our hospital had been experiencing an increasing number of adverse drug events in recent years. This problem, we discovered, was not uncommon. The Institute of Medicine issued a landmark report in 1999 titled "To Err is Human," citing as many as 98,000 people die in hospitals each year due to preventable medical errors. According to the Joint Commission's Sentinel Events database, 65% of Sentinel events result from communication breakdowns. Communication breakdowns are the most frequent reason for root cause analysis in the database. Communication breakdown results in loss of trust in the healthcare system, lower patient and healthcare worker satisfaction levels, physical and emotional pain and suffering, and reduced societal productivity at an estimated cost of $17 billion to $29 billion per year in hospitals. As a result of this evidence, the Joint Commission directed in 2006 that a standardized approach to handoff communications be developed by organizations, which would include an opportunity to ask and respond to questions. In response to the Joint Commission directive, Dr. Michael Leonard from Kaiser Permanente Denver developed a standardized communication tool known as SBAR to improve the effectiveness of communication between healthcare providers. This tool was adapted from the U.S. Navy and the aviation industry. It provides the format for information to be conveyed in a standard and consistent way. SBAR is an acronym for Situation, Background, Assessment, Recommendation. Since its introduction, this tool has had further adaptations such as iSBAR and iSBAR-R, where I stands for Identify and R stands for Readback. These adaptations were not included in this initial trial. This tool seeks to overcome the barriers to communication often present due to the differences between how nurses are trained to communicate and how physicians are trained. Traditionally, nurses are trained to speak in generalities, allowing the physician to draw a conclusion. Physicians are trained to listen to the highlights. This can lead to miscommunication and misunderstandings. It is felt that SBAR helps to bridge the gap in communication between nurses and physicians, improving communication and increasing patient safety. This must be qualified by stating that the use of SBAR may occur and poor communication can still result. SBAR does not overcome other barriers to communication such as not listening, multitasking when being spoken to, avoiding eye contact when speaking to another person, or not reading back critical information. Successful communication includes use of SBAR with good communication skills. A review of the literature reveals the following demonstrated benefits of using SBAR. There was improvement in clarity and content of communication during a simulated clinical scenario with medical students. Outcome measures of adverse events and medical reconciliation improved after implementation of SBAR. Improved teamwork, there's improved safety climate survey reports. Qualitative studies report themes of positive communication, strong foundation for communication, and increases awareness. Qualitative studies also show less experienced nurses feel more comfortable communicating with physicians using the SBAR tool. It was determined by the hospital administration that SBAR be trialed first in the ICU for 6 months. This decision was made for several reasons. First of all, the incidence of adverse events, particularly adverse drug events, had risen in the ICU over the past 2 years. This rise was felt to coincide with the use of a hospitalist group of physicians caring for inpatients and an intensivist group of physicians who cared exclusively for ICU patients. This unit had the highest incidence of adverse drug events in the facility. In addition, the ICU had experienced a large turnover in nursing staff, and several staff nurses had been in this setting for less than 2 years. The ICU was relatively small, 14 beds, which would also allow for closer monitoring of the use of SBAR. The objective of this study was to evaluate whether the use of SBAR communication tool resulted in a decrease in adverse drug events as identified by the IHI trigger tool in this ICU. The SBAR communication tool was introduced using Rogers' diffusion of innovations theory. Rogers' change theory involves the following steps: knowledge, persuasion, decision, implementation, and confirmation. Knowledge is defined as the period of time when people involved gain an understanding of the innovation or new idea and how it functions. The key players in this study were identified as the ICU nursing staff, the hospitalist physician group, the intensivist physician group, and ancillary departments, cardiopulmonary, lab, and imaging. These key players were introduced to the SBAR communication tool at a special series of staff meetings. At these meetings, the findings of the IOM report were reviewed with the staff, as well as the Joint Commission determination that handoff communication provides for the opportunity for discussion between the giver and receiver of patient information. The SBAR tool was displayed on a large laminated poster and the basic elements reviewed with staff. The meetings were concluded with the information that further meetings would be held for training in the use of SBAR communication. Persuasion refers to the formation of a favorable or unfavorable attitude regarding the new innovation. Training sessions included the following: a review of the effects of poor communication, how SBAR was created, benefits of SBAR to physicians and nurses, clinical and non-clinical examples of how SBAR can be used were given, and practice scenarios using SBAR were done. Staff were instructed that when all nursing staff, the intensivist, the hospitalist, and appropriate ancillary staff had been in service on SBAR, they would be contacted with a date to start utilizing the communication tool. Ancillary staff were included so they would be familiar with the SBAR format the nurses were using to communicate to them with. Posters were placed around the unit, in the bathroom, and the staff lounge to remind staff of the communication tool. In-services for all key players were held within a 14-day period of time. It was understood by all of these players that the SBAR communication tool would be used by nursing staff to communicate with physicians and ancillary members of the care team. Decision occurs when there is involvement in activities that lead to a choice to adopt or reject the innovation. The start date was announced. SBAR communication reminder cards were handed out to staff members. SBAR communication sheets were placed near phones and next to every computer area. SBAR champions were identified for the ICU, 2 RNs on days and 2 RNs on nights, working on alternating shifts with a responsibility to answer any questions staff had regarding the use of SBAR when on duty. Their names and pictures were placed in the staff lounge, along with an invitation to ask them any questions regarding SBAR. The clinical educator also left her name, picture, and contact information in the lounge if staff needed further assistance. Implementation is putting the innovation to use. Trained observers spent the first 2 weeks after implementation began in the clinical area to determine if the tool was being utilized by nursing staff. Results were placed into graphs and posted in the unit to show SBAR usage. Random monitoring by trained observers continued over the course of the next 6 months to assess if the tool was being used. As you can see, the day shift increased their uses of SBAR from 28% to 37% in the first 2 weeks. The night shift increased their usage from 12% to 17%. Confirmation occurs when the decision to use the innovation is reinforced. Retrospective chart reviews were done of all ICU patients in the 6-month period of time the SBAR trial was conducted. These included admissions to ICU as well as patients transferred into the ICU from other units. The global trigger tool was used to assess adverse drug events. Surveys were sent via email to all key players before and after the trial. According to Rogers, the rate of diffusion of the innovation follows the S-curve pattern. Therefore, people respond to the change at first slowly, then very rapidly, followed by a longer period of adaptation. There are 5 categories of followers in this process: innovators, early adopters, early majority, the late majority, and laggards. The first group is called the innovators. One of the ICU nurses was an innovator. She had a master's degree in nursing education and was identified as one of the SBAR champions. She was familiar with SBAR and was active in promoting its use among ICU staff nurses, particularly the newer staff nurses. There were several early adopters. These were the nurses who had been in ICU for less than 1 year. They liked the SBAR tool because it helped them to organize their thoughts before speaking to a physician. This gave them a greater sense of confidence when speaking. Some of the early majority were per diem nurses who worked frequently in the unit. They appreciated the tool because it gave them greater confidence they had all the information necessary on patients they were not familiar with. The late majority were mostly night nurses who eventually began to use the SBAR tool. They were used to seeing the hospitalists in the unit at night and had a very informal relationship with them. After seeing the graph of SBAR usage broken down into days and nights, they began to use the tool. The laggards were identified as nurses in the ICU who had the most experience. They seemed to feel they did not need to use the tool. They did acknowledge there was benefit to the newer nurses using it. When they saw the improved outcomes after 6 months, they began to use the tool also. The tool used to measure adverse drug events was the Trigger tool developed by the IHI. This is a very detailed tool that is used by trained reviewers to retrospectively review a minimum of 20 charts per month. The Trigger tool worksheet has a module dedicated to medication triggers, which the reviewer uses in the review charts. A positive trigger does not indicate an adverse drug event occurred, it is a clue one may have occurred. A positive trigger stimulates further review into the chart for evidence the patient experienced harm. A level of the severity of harm is assigned. 2 reviewers examine the same chart, compare findings, and then record findings on the Global Trigger Tool review summary sheet. A physician reviewer then examines the summary sheet, and the number of adverse events or harm categories may be adjusted after this review. Data collection may be presented in 3 ways: adverse events per 1,000 patient days, adverse events per 100 admissions, or the percent of admissions with an adverse effect. The rate of adverse drug events in the first 6 months before this trial was 27.1% per 1,000 patient days. The rate of adverse drug events for the 6 months during the trial was 13.9% per 1,000 patient days. "55 surveys were sent to the key players in this study. The number of responses received back before the trial began was 35. After the trial, 45 responses were received. The survey contained the following 4 questions, with the first 3 question responses measured on a Likert scale of 1 to 10. The first question was, how confident are you use of SBAR will improve nurse-physician communication? Before the trial began, the result was 3.5. After the trial, the result was 6.8. How confident are you that the use of SBAR will improve patient safety in the ICU? Before the trial, the result was 2.1. After the trial, the result was 5.7. How confident are you that SBAR will be utilized or has been utilized in nurse-physician communications in the ICU? Before trial, the result was 3.3. After the trial, the result was 7.8. The last question asked was, how often do you use the SBAR communication format? 25 nurses responded to this question. 3 nurses said that they use it 0 to 25% of the time. 5 nurses responded they use it up to 50% of the time. 15 nurses said that they use it 75% of the time, and 2 nurses said that they would use it up to 100% of the time. It was discovered that SBAR was a significant factor in the reduction of adverse drug events in this 6-month trial in the intensive care unit. In summary, communication breakdowns produce an unsafe culture within hospitals, resulting in preventable adverse patient events. SBAR provides a standardized evidence-based format to promote clear communication between members of the healthcare team. Physicians and nurses appreciate the value of SBAR communication, and in this study, implementation of SBAR resulted in a decreased number of adverse drug events,